Hello, I'm Professor Emily Mercuri, and this is Chapter 22, Anticonvulsants, Antiparkinsonian Drugs, and Agents for Alzheimer's Disease, in Essentials of Pharmacology for Health Professions, 9th edition. Chapter Objectives. Upon completion of this chapter, the learner should be able to describe the different types of seizures, list the medications used for each type of epilepsy and common side effects, describe the drug therapy for febrile seizures, list the drugs used for Parkinsonism and common side effects, describe the patient education appropriate for those receiving anticonvulsants and anti-Parkinsonian drugs, describe the drug therapy for the treatment of restless leg syndrome, and describe the drugs for the treatment of Alzheimer's disease. Anticonvulsants. You'll recall that anti means against, and then the word convulsant refers to convulsing, which is when a person suffers violent, involuntary contraction of the muscles, producing contortion of the body or limbs. So the primary disorders that anticonvulsants will be used for are seizure and epilepsy disorders. Seizures are defined as brief, abnormal neuronal discharges in the brain that occur repeatedly for a variable length of time. Seizures can occur randomly or be related to conditions or injuries. Anticonvulsants are used to decrease the number or severity of seizures. Epilepsy is defined as 2 or more unprovoked seizures, meaning there's nothing that we can significantly say caused this to occur, separated by a period of 24 hours. Epilepsy is the 4th most common neurological disorder in the United States. Some other things that can cause seizures, something like a head injury, a traumatic brain injury, a sudden trauma, and things like withdrawal from alcohol and other nervous system depressants. As the nervous system then becomes overly excited, as we learned about last week, that can lead to seizures. It can lead to a decrease in the seizure threshold, making seizures more common. It's important to note that there are different types of seizures. The first category here is primary generalized seizures, which are characterized by widespread electrical discharge. There are convulsive seizures, including tonic, where the entire body goes stiff or rigid, clonic, where there's this kind of jerking, repetitive motion of the muscles, and tonic-clonic, which is a mix of both. Convulsive seizures are what we are typically more accustomed to picturing when we think of a seizure, more often depicted on television where the whole body is kind of thrashing and moving. There are also non-convulsive generalized seizures, including absence, myoclonic, and atonic. Absence seizures are typically there is this moment where the person becomes unconscious, but they're oftentimes kind of staring straight ahead, and they aren't really responding to you, but then they very quickly come to. So there's not this long post-ictal phase, which is a phase marked by confusion and disorientation afterwards. And so, as you can imagine, those are harder to diagnose, and oftentimes they occur in children, and they're just mistaken as daydreaming. So that's something important to be aware of. Myoclonic, there is some twitching, rapid movement of the muscles in an area, or like a sudden involuntary jerk, shake, or spasm, but not to the level of the whole body convulsing. And then atonic is where there is no tone to the muscle and suddenly the body just kind of goes floppy. The initial treatment for generalized seizures, we want to prevent injury. Imagine any of those things happening and somebody's, let's say, standing up or walking. They could just fall to the ground. They might jerk and thrash and hit their head. And so it's important that we prevent injury. Ideally, we want to have the area around them padded, especially under their head. We want to try to safely turn them to their side because vomiting or excessive foaming of the mouth can occur, and we don't want them to choke. But what we never want to do is stick something in somebody's mouth to stop them from biting their tongue. That used to be something that was done, but that can cause a lot of risk and harm, including breaking teeth. So we never want to shove something in somebody's mouth, but we do want to do our best to try to turn them to their side, make sure that they are, there's some padding around them, that they're not going to injure themselves. We also don't want to grab and hold their body tight to prevent them from thrashing, because we could cause more injury that way. So just try to limit the damage that can occur. Partial seizures occur with focal electrical discharge, so only in one area of the brain. Simple partial seizures, there is no loss of consciousness. It could be one part of the body just starts moving or jerking, but the rest of the body is intact and there's no loss of consciousness. It could be something like numbness or tingling. It could be a sensation, not an actual muscle movement. So again, a little bit harder to diagnose often. And then a complex partial seizure, there is a loss of consciousness, but it is only occurring in one part of the brain that leads to this. And in a complex partial seizure, they may have that kind of absent behavior, but then they will have this post-ictal phase as well. Knowledge check. Epilepsy is defined by how many unprovoked seizures separated by a 24-hour period. A1, B2, C3, D4. The answer is B2. Drug therapy for generalized and partial seizures. First-generation anticonvulsants. The aim of this therapy is to prevent seizures without oversedation, and the dosage is adjusted according to the individual patient response and serum drug level when available. What that means is that the patient will about once a month typically get blood levels drawn to make sure that the medication is in the therapeutic range, depending on what the medication is. When we talk about oversedation, remember that seizures are an increase in central nervous system activity, an inappropriate increase. And so we need to kind of bring down the excitability of the central nervous system, but we don't want to overly sedate or cause impairment to the patient, as this is a medication they'll be taking every day. Examples: valproate, the brand name for that is Depakote. Lamotrigine, the brand name is Lamictal. Levetiracetam, the brand name is Keppra. Carbamazepine, the brand name for that one is Tegretol. Oxycarbazepine, the brand name is Trileptal. Or phenytoin, and the brand name for that is Dilantin. Side effects of these medications: sedation, ataxia, dizziness, and headache. Ataxia means lack of coordination. Blurred vision, nystagmus, and diplopia, which is blurred vision. Rash and dermatitis, Stevens-Johnson syndrome, and lupus-like symptoms. Megaloblastic anemia, which can be treated with folic acid. Osteomalacia, which is bone softening, can be treated with vitamin D. And then something to be aware of is that the ingestion of grapefruit juice can potentiate the drug effects or make them stronger. So patients that are on these medications should be educated not to ingest grapefruit juice. Drug-to-drug interactions. For phenytoin, cimetidine, isoniazid, salicylates, SSRIs, sulfonamides, topiramate, and trimethoprim may increase the levels in the body. Something to be careful with, and typically they won't be prescribed at the same time. Phenytoin, phenobarbital, and rifampin can decrease carbamazepine levels. So again, oftentimes these are ones that they're not going to prescribe at the same time. And then calcium channel blockers, cimetidine, macrolides, azole antifungals, certain antipsychotics, protease inhibitors, valproic acid, and isoniazid can increase carbamazepine levels. This is really important, and I don't expect you to have all of this memorized. I certainly don't, and I've been working as a nurse for quite a while now, but it's important that when a patient comes in and they are on a lot of medications, that we are checking what other medications they're on. You would think, oh, their primary doctor's doing that. But oftentimes people will bounce back and forth between different doctors. And sometimes the doctors are not communicating as well as we think they are. And so the pharmacy is responsible for this, but also we're responsible as we work in healthcare if we are a nurse, an LVN, a pharmaceutical technician. We want to make sure that someone is not suffering from what we call polypharmacy, which means there's just a bunch of medications ordered and no one has gone and done a reconciliation and made sure that there aren't medications that aren't interacting or that can't cause problems together. Knowledge check. Which is not a side effect commonly found in the use of epilepsy medication? A. Blurred vision. B. Rash. C. Bone softening. D. Alertness. And the answer is D. Alertness. You are more likely to have drowsiness, not alertness. Drug therapy for febrile seizures. So febrile seizures occur in children. Actually, approximately 1 in 30 children have a febrile seizure at one time or another, which is a pretty staggering statistic. Usually these occur between the ages of 6 months and 6 years, most commonly 6 months to 3 years. The routine treatment is going to be to find the cause of the fever and take measures to control the fever. So this is occurring because of this high temperature of the body. We want to try multiple antipyretic or anti-fever drugs, usually ibuprofen, Tylenol, either rotating or giving them concurrently. The American Academy of Pediatrics Subcommittee on Febrile Seizures does not recommend the use of anti-epileptic drugs for children with 1 or more simple febrile seizures. So we are not going to start them on an anti-epileptic drug. We're going to treat them with those antipyretics. If the child has complex febrile seizures, especially if they're multiple or they're lasting for a long time, they may be prescribed anti-epileptic drugs on an individual basis. Typically, children do grow out of febrile seizures, but if they have one, there's about a 1/3 chance that they will, 1 out of 3 children who have one will likely experience at least 1 or 2 more during childhood. So once they've had one, they're more likely to have another one. It's important to educate parents on what this looks like and on controlling the fever. Knowledge check. Which drug category is recommended in the treatment of febrile seizures? A. Antihistamines. B. Anticonvulsants. C. Antipyretics. D. Anti-inflammatories. And the answer is C. Antipyretics. Drug therapy for absence seizures. So for absence seizures, the drug of choice is ethosuximide, which is Zerontin. It suppresses the paroxysmal 3 cycle per second spike and wave activity associated with loss of consciousness. All that means is it works on this specific pathway that seems to work better for absent seizures versus other types of seizures. If the ethosuximide is ineffective, other drugs, including clonazepam, Klonopin, valproic acid, Depakote or Depakine, and lamotrigine, Lamictal, can be used. Side effects of the Zerontin: sedation, dizziness, headaches, aggression or irritability. GI distress, including anorexia, nausea, vomiting, and diarrhea. If taken with food, this will minimize the effects. And some cautions or contraindications include hepatic, which is liver or renal disease, liver or kidney disease, pregnancy and lactation, and increased caution that this can cause pancreatitis if they're taking the valproate, or it can, if someone already has a history of pancreatitis, this could be a contraindication to taking that med. Drug-to-drug interactions. Abrupt discontinuation interactions occur between ethosuximide and carbamazepine, phenytoin, primidone, phenobarbital, valproic acid, rifampin, isoniazid, and antiretroviral protease inhibitors. So essentially, we don't want to ever discontinue these drugs rapidly, and if we do, especially the interactions that can occur are between the ethosuximide and any of these drugs within this category. So some patient education for your anticonvulsants. Reading the provided medication guide is important before they start taking an anticonvulsant and each time they get a refill, just to refresh themselves on what might occur, what the side effects are, etc. They should take caution with driving or operating machinery until they're regulated with the medication because it can cause drowsiness or dizziness. Hopefully, over time, again, we don't want to oversedate with these. Their body will get used to it and they will not be drowsy with each dose. They need to report side effects such as rash or eye problems, staggering or being unsteady on feet, slurred speech, or any other symptoms. Ensure careful oral hygiene until tenderness of the gum subsides as treatment progresses because these can cause gum tenderness. Always take the medication on time and never omitting a dosage because abrupt withdrawal can lead to status epilepticus. What is status epilepticus? I know there was a little sidebar on your other slide. Status epilepticus is when the seizure will not stop. So it is the seizure is going on, or there's multiple seizures in a row, and it's a very dangerous medical emergency occurring when the seizure lasts longer than 5 minutes or those multiple seizures happen kind of back to back. And so if they are relying on this medication to stop the seizures and they abruptly discontinue taking it, it can lead to worsening seizures leading to the status epilepticus. They should always wear a Medi Alert tag or bracelet in case of an accident or injury, and take the medication with food or milk to lessen stomach upset. Some other education: check with the healthcare provider before initiating any new treatments, including over-the-counter or herbal products, because anticonvulsants are associated with numerous and potentially harmful drug-to-drug interactions, as we saw on the last few slides. No ingestion of grapefruit juice while on carbamazepine, Tegretol, because it will potentiate the effect. Parents and teachers of patients on anticonvulsants should be cautioned to observe and report changes in cognitive function, mood, and behavior. And some anticonvulsants can cause an increased risk of birth defects if used during pregnancy. Women of childbearing age taking anticonvulsants should be educated on using proper contraception. Knowledge check. Which patient education would be provided to patients using anticonvulsant medications? Mark all that apply. A. Ensure careful oral hygiene. B. Wear Medi Alert bracelet at all times. C. Check with physician before starting any new medications. D. Take with food or milk. The answer is A, B, C, and D, all of the above. Antiparkinsonian drugs. Antiparkinsonian drugs are usually given for Parkinson's disease, which is a chronic neurological disorder characterized by fine, slowly spreading muscle tremors, rigidity, and generalized slowness of movement called bradykinesia. There's a nice graphic here on the side of the slide that talks about Parkinson's disease. Parkinson's involves the brain and the neuron cells. There is this terminal branch that requires dopamine as a signaling agent, and there is a weak signal of the dopamine. It's not, the underlying pathology is not completely understood, but basically that normal dopamine activity as it relates to acetylcholine is diminished. So that causes this overactivity of cholinergic output. And what we're really treating here is that overactivity of the cholinergic output. Some signs and symptoms of Parkinson's: memory loss, dementia, anxiety, depression, and hallucinations. This is more towards the late stages of Parkinson's. Slow blinking, no facial expression, drooling, difficulty swallowing as the muscle movements slow down, shaking, tremors, loss of small or fine hand movements, problems with balance or walking, stooped posture, aches and pains and constipation. Again, this bradykinesia, this slowness of movement. People with Parkinson's will get very stiff and rigid. And so the medications it's really important that they're given right on time to avoid this from occurring, because if it already occurs, then we're kind of chasing those symptoms. Some drug classifications for anti-Parkinsonian drugs: dopamine replacement, so giving this exogenous dopamine, Sinemet, Parcoba, or Sinemet CR. The side effects are dyskinesias, nausea, vomiting, and anorexia. Behavioral changes, including anxiety, agitation, confusion, sleep disturbance, depression, hallucinations, and psychosis. And it can also lead to hypotension, which is low blood pressure, dizziness, and syncope, which is fainting. Some comments about Sinemet. Abrupt discontinuation of this bed could lead to neuroleptic malignant syndrome. What does that mean? Neuroleptic malignant syndrome is when it's a potentially fatal reaction, but there is a mental status change, rigidity, fever, autonomic dysfunction, and so we can cause this kind of swing over into this very dangerous over activity of the receptors. Another drug classification is dopamine agonists, such as Parladel, Mirapex, Requip, and Nupro. Side effects are psychosis, hallucinations, obsessive behavior, impulsivity, confusion, insomnambulism, which means sleepwalking. Could lead to excessive sedation, hypotension, syncope, and peripheral edema, and nausea and vomiting. So fairly similar side effects to the dopamine replacement. What dopamine agonists are recommended as initial monotherapy, meaning the only therapy, for those younger than 60 years, as dopamine agonists are believed to have a neuroprotective effect. So neuroprotective, they are hopefully protecting the neurons from further decline. Dopamine agonists mimic dopamine by binding to and activating dopamine receptors in the brain. Anticholinergics, cogentin, and artane. Side effects are dry mouth, dizziness and drowsiness, blurred vision, constipation or urinary retention, confusion, depression, nausea, and tachycardia. Remember your anticholinergics: can't pee, can't see, can't spit, can't other word. And so we want to think about, you can see that there: dry mouth, blurred vision, constipation, urinary retention. Okay, so anticholinergics can have all of those side effects. We want to use these in caution with patients that have glaucoma and benign prostatic hyperplasia, BPH, that is an enlarged prostate, and that those people oftentimes already struggle with urinary retention, so that could be dangerous. Another drug classification is COMT inhibitors, such as Compton or Stalevo. COMT stands for catechol-O-methyltransferase, which is an enzyme that metabolizes catecholamine neurotransmitters, such as dopamine. And an inhibitor can help to lower the metabolism of the agent, and so it kind of stays on that receptor longer and allows it to be more utilized. The side effects are orthostatic hypotension, which is low blood pressure when changing position, hallucination, dyskinesia, nausea and vomiting, diarrhea and abdominal pain, and orange coloration of the urine. COMT inhibitors increase the concentration of levodopa and dopamine, allowing the patient's dose of levodopa to be lowered and resulting in a decrease in the incidence or severity of the dose-related side effects of medications such as levodopa. So oftentimes these are given in conjunction so that they can use a lower dose of the other medication. MAOB inhibitors, Azilect, Eldepril, Zellipar, and Xadago. MAOB is monoamine oxidase B. It's another enzyme that plays a role in breaking down neurotransmitters. The side effects you can see are very similar to those above, in addition to confusion, dry mouth, vivid dreams, and headache. Comments here: an orally disintegrating tablet, ODT, formulation of Selagelene Zellipar is available as an adjunct to levodopa. This is absorbed through the buccal membrane, so the cheek, avoiding first pass hepatic metabolism. So it is not absorbed through the GI tract, it goes directly through the cheek, and so that's kind of a thin mucosal membrane. So that bypasses the hepatic metabolism. And then given as an adjunct, so in addition to levodopa, similar to the COMT inhibitors, it's going to allow that to work and remain effective on the receptors and allows the person to lower their dose. And then other agents listed are Semitrel. The side effects of this are CNS disturbances, headaches, weakness, and insomnia, heart failure, edema, and hypotension, GI distress, constipation, and urinary retention. This medication is, interestingly enough, classified as an antiviral. It's used to treat Parkinsonian symptoms associated with the prolonged use of phenothiazines, carbon monoxide poisoning, or cerebral arteriosclerosis in older adults. So while it's an antiviral, it's used to treat some of the symptoms associated with Parkinsonism or Parkinson's disease. Knowledge check. Which is not a common side effect for dopamine agonists? A. Hypertension. B. Nausea and vomiting. C. Peripheral edema. D. Excessive sedation. The answer is A. Hypertension. Remember, it can cause hypotension, not hypertension. Antiparkinsonian drug patient education. Patients taking antiparkinsonian medications should be provided with the following patient education. Administration on a regular schedule as prescribed with food to lessen GI distress. And carbidopa-levodopa should be given with a low protein meal if food is necessary to offset nausea, because the protein can bind and cause a lessened effect of the medication. It's important to avoid abrupt withdrawal of medications, which may greatly increase the Parkinsonian symptoms and the risk of neuroleptic malignant syndrome. Sometimes several weeks is required after starting before the benefit is apparent, so we don't want people to quit the medication thinking it's not working, because sometimes it takes time to build up in the system. Take caution with central nervous system drugs, alcohol, or antihypertensives. If they are taking other medications, including vitamins, they need physician approval and medication reconciliation. Caution with driving or operation of machinery. Patients should know that the drugs may cause drowsiness, dizziness, or lightheadedness. With pramipexole, there may be no warning signs before falling asleep when engaged in activity of daily living, so that particular med also, it can be a very sudden, where you'll just fall asleep. Report adverse side effects to the physician, such as involuntary movements, blurred vision, any of those anticholinergic effects we talked about, or palpitations, mental changes. With dopamine agonists, there may be intense urges to gamble or spend money, increased sexual urges, bouts of binge eating, and other intense urges. So the dopamine agonist can cause this kind of impulsivity or cravings for risky behavior, so that's very important to note. Reporting any sign that the drug is no longer effective after prolonged use. So sometimes after months or years, the dosage may need to be increased, or as we talked about, some of those adjunct drugs that can help you remain on a lower dose. So we shouldn't be changing the doses without medical supervision. It's important that patients maintain physical activity, self-care, and social interaction, which is an essential part of therapy. And it's important that people know to rise slowly, because many of these medications can cause that orthostatic hypotension. When someone's changing position, their blood pressure may drop very low. Moving on to restless leg syndrome. Etiology. Restless leg syndrome is a sensory motor disorder characterized by a distressing urge to move the legs. Restless leg syndrome is often accompanied by aching, pulling, burning, itching, or tingling sensations. It often interferes with the person's ability to rest or sleep, and it may be primary or secondary to other causes. Medications for primary restless leg syndrome involving the central nervous system and dopaminergic pathways, they are going to use dopamine agonists. These include pramipexole, Mirapex, ropinirole, Requip, and rotigotine, which is a Nupro patch. It actually absorbs through the skin. For secondary restless leg syndrome, such as neuropathy related to diabetes or extensive back surgeries, drugs including gabapentin, Neurontin, benzodiazepines such as clonazepam, and opioids such as hydrocodone, oxycodone, and tramadol are used. So again, for primary, we're using more of these neurological drugs. For secondary, we are using drugs that act on the nerves or on the pain itself or causing some mild sedation to help with the symptoms. Knowledge check. Which drug is a second-line agent used in the treatment of restless leg syndrome? So remember, second line, not our first medication we would go to. So A, ropinirole, Requip, B, pramipixole, Mirapex, C, gabapentin or Neurontin, D, rotigotine, which is a Nupro patch. And the answer is C, gabapentin. The others are all first-line agents. Case study. A patient informs their physician that they are having a difficult time sleeping. So when they lay down in their bed, their legs begin to burn, twitch, and experience tingling that keeps them from falling asleep. Upon examination, the physician diagnoses the patient with A, Parkinson's disease, B, restless leg syndrome, C, hypoglycemia, D, hypotension. The answer is B, restless leg syndrome. This next section is agents for Alzheimer's disease, but your book does not provide a PowerPoint describing Alzheimer's, and so I want to give you a brief overview of what it is in case you're not familiar. So Alzheimer's is the most common cause of dementia, and Alzheimer's disease is the biological process that begins with the appearance of this buildup of proteins in the brain in the form of plaques and neurofibrillary tangles. This causes brain cells to die and the brain to shrink over time. So Alzheimer's is characterized by this memory loss. It can begin as more subtle, where the person might forget a recent conversation. They might start having some short-term memory loss where they can't remember maybe what they ate that day. They might start to misplace things like keys, that kind of thing. And then as it progresses, it can lead to mood disturbances, behavior changes. It can lead the person to not have any sense of memory, or they will lose all short-term and only remember long-term. Eventually, it can even progress to where the person does not know who they are and forgets how to perform functions such as eating, drinking, toileting. They become where they can't take care of themselves, and oftentimes it will just progress until they're not even swallowing anymore, that kind of thing. It can lead to death. As you can imagine, as this neurodegenerative disease, it's very devastating for patients and for families who receive this diagnosis. And so we can help support by just therapeutic communication, listening, and then there are medications that can help slow Alzheimer's from progressing, but there is no cure for Alzheimer's disease. So the medications we can use are your cholinesterase inhibitors, donepezil, brand name Aricept, rivastigmine, brand name Exelon, and galantamine, brand name Razidine. So what these cholinesterase inhibitors do, they increase the availability of acetylcholine, which is a neurotransmitter, by blocking the enzyme that breaks it down. And so by doing this, they allow it to stay on the receptors longer, which enhances memory and cognitive function. The side effects are GI upset and hepato or liver toxicity. Drug-to-drug interactions occur with anticholinergics as well as cholinergics. Reason being, it's acting on the same pathways. So your cholinergics, those are going to increase neurotransmission, so those will potentiate each other. Your anticholinergics are going to act directly against these cholinesterase inhibitors, so we don't want to give them together. We don't want to potentiate or block the effects, so it's important that you're under a provider's care and knowledge is in terms of your medication reconciliation when taking these medications. The other main category are your NMDA receptor antagonists, and the medication for this is memantine or Namenda. NMDA receptor antagonists work by blocking excessive glutamate activity, which again is a neurotransmitter. Excessive activity of glutamate can damage nerve cells and impair memory and thinking. And so by blocking this excessive activity, we can help slow down disease progression and improve cognitive function. Glutamate is an excitatory neurotransmitter. And so it's an important one, but if we're having excessive activity of it, it can kind of break down things a lot quicker. It's called excitotoxicity, interestingly enough. So the side effects of this are confusion, cerebrovascular disorders, falls and agitation, as well as dizziness, headache, constipation, and cough. Interactions occur with other NMDA antagonists, amantadine, ketamine, and dextromethorphan, and certain antiarrhythmics. So again, always important to do that medication reconciliation. Make sure you're not taking things that interact with each other. Knowledge check. Which is a contraindication for donepezil? A, nausea, B, jaundice, C, headache, D, gastroesophageal reflux disease. When I'm looking at this list, I'm automatically eliminating some of them because they are more like side effects than contraindications. So I want you to always kind of look at that carefully. The answer is B, jaundice. Because donepezil can cause hepatotoxicity, jaundice is a sign that there is liver damage already, so that's a contraindication to taking it. Self-assessment for this chapter. What are the two different groups of seizures that are differentiated by how they begin in the brain? What are the different classifications of anti-Parkinsonian drugs? And what are the common symptoms associated with restless leg syndrome? Thank you for listening. This has been Chapter 22 in Essentials of Pharmacology for Health Professions, 9th edition.